posteriorly dislocated intraocular lens is one of the situations that a retinal surgeon has to encounter in day-to-day practice. Surgical planning in such cases involves explantation of the dropped IOL and visual rehabilitation with implantation of a secondary IOL, either an anterior chamber or iris-fixated or scleral-fixated IOL. Crucial step of this procedure is to safely explant the IOL without causing damage to the retina, iris, and cornea. A bimanual technique is commonly used to levitate the IOL from the posterior chamber into the anterior chamber. After picking up the IOL from the retinal surface, it is manipulated into the anterior chamber while a second instrument is used to support the IOL from behind, which is usually the light pipe. Sometimes a Sinskey hook or an iris spatula introduced from the anterior chamber is also used. This is followed by a handshake technique of holding the lens with a forceps introduced through the scleral tunnel to explant the LOL. This step of change of hands and introduction of forceps into the anterior chamber when a part of the IOL is in front of the iris and a part of the IOL behind the iris leads to an unstable anterior chamber and globe. The maneuvers have to be quick and precise to prevent sudden hypotony. Sometimes during this step, a proper grasp of the levitated IOL is not possible due to hypotony or fluid currents leading to IOL dropping back into the posterior chamber. We describe a stepwise approach to consistently explant any IOL using a unimanual pronation-supination (UPS) technique. Surgical plan involves a pre-placed scleral tunnel without entering into the anterior chamber is fashioned at the start of the pars plana vitrectomy before placing the sclerotomies. A thorough vitrectomy including PVD induction is performed to free the IOL from all the vitreous adhesions. It is preferable to place perfluorooctane liquid over the posterior pole to protect the macular area from any inadvertent injury. This is followed by making the anterior chamber side ports and anterior chamber entry through the pre-placed scleral tunnel to facilitate the removal of the IOL. The anterior chamber is filled with viscoelastic. Under wide-angle visualization, the IOL is firstly oriented such that the inferior haptic is directed away from the forceps tip, and secondly, the long axis of the IOL must be perpendicular to the axis of the forceps. Once the IOL is oriented in this fashion, the optic of the IOL is held firmly just beyond the junction of the inferior haptic optic. The IOL is gently brought anteriorly in the retropupillary area. Now, the IOL is maneuvered into the anterior chamber by using the UPS IOL explant technique. This is accomplished in two continuous steps. First, the inferior haptic is placed above the iris by simultaneously moving the IOL bit superiorly under the iris and pronating the hand slightly to rotate the IOL along the long axis of the forceps. This results in placement of the inferior haptic above the inferior iris. The second step is performed as a continuation, without releasing the grip. The IOL is slightly decentered inferiorly while the pronated hand is subjected to a supination movement along the axis of the forceps. This results in the superior haptic being placed above the superior iris. With practice, one may also achieve this pronation-supination movements by rotating only the forceps along its long axis, first in a counterclockwise manner, pronation step, followed by clockwise rotation, supination step, with the fulcrum at the sclerotomy port. The whole explanation process can be quickly performed in a closed chamber with very good control over the surgical steps. Once both the haptics are above the iris, it can be removed from the anterior chamber easily. We recommend following the steps mentioned in our method to consistently remove any posteriorly dislocated IOL in a systematic way rather than randomly picking up the IOL, sometimes holding the optic, sometimes holding the haptic. Also orienting the IOL in a particular way and holding it at the same area every time before picking up from the retinal surface eliminates the unpredictability of the maneuvers required to deliver the IOL from the posterior segment to the anterior segment. The proposed unimanual pronation-supination method is a versatile technique that can be employed consistently to remove any type of IOL safely and easily.